Hey, good evening, everyone. I hope you can hear me well. Welcome, welcome, welcome. Thank you so much for joining us for another evening of discussion and learning and advancing our knowledge here. Thank you so much for joining us. Please look in the chat. We have a pre-test set up for you. So if you could go ahead and fill out that pre-test, that would be wonderful. We will start at 7 o'clock sharp. And at 7 sharp, I'll be handing over to our moderator for tonight's session. And the moderator, of course, is Dr. Sophie Abrikian. So, ladies and gentlemen, trust me, when I say we have a nice one for you tonight, we have a nice one for you tonight. All right? So, let's have our pre-test done. I hope you guys are good. A little bit of mellow music in the background there until 7. Just let me know in the chat if you have any issues. I'll try to help you so we can have it sorted out. Have a good one. Again, thank you guys. Thank you so much for joining us. Thank you so much for joining us. Your pre-test information is in the chat. Go ahead and fill out the pre-test. We begin our webinar in 60 seconds. 60 seconds. All right, someone says a pre-test is not coming up. Let me know what's happening. I'm clicking on it myself here and it's working. Please let me know specifically the issue that you're having so we can have it fixed immediately. All right, thanks for keeping us posted. We don't want you to have any issues at all. The pre-test is up and you should be able to have it completed. Please let me know. All right, see the response is coming in. So that means our pre-test is now doing what it's supposed to be doing. Thank you very much. All right, as promised, it is 7 p.m. and I'm now happy to hand you over to our moderator for this evening's session, and that is Dr. Sophie Abrikian, an AGPJ executive. Dr. Abrikian, over to you. Have a wonderful evening, guys.
Good night, everybody. Welcome to AGPJ's webinar on sexual disorders, clinical and ethical challenge on Unearthed. We have several very great speakers to come, and I'm looking forward to it as well. So I'm going to hand over to Dr. Gordon now, and then we'll start. Go ahead, Dr. Gordon.
Thank you very much, Sophie. Good evening, colleagues. A very special welcome to Dr. ALVERSTON Bailey, our MAJ Foundation Chairman, and welcome to the moderator, Dr. Abrikian. Welcome to our presenters, Professor William AIKEN, Dr. Jackie Campbell, Dr. Karen Carpenter, and very much thanks to sponsors Medimpex, to IT support from Colgate, and to our administrator, Lynn. I'm Dr. Gordon, President of the Association of General Practitioners of Jamaica. It is my pleasure to bring greetings on behalf of the association as we join with MAJ Foundation in staging this exciting webinar titled Sexual Disorders, Ethical and Clinical Challenges Unearthed. This evening webinar is special for a number of reasons. One, we have a very exciting and interesting lineup of speakers who I'm sure will titillate our interest in the topics. And secondly, it marks a collaborative effort between the association and the foundation. The purpose of the webinar is twofold: to raise funds for the foundation to carry out its outreach program to its members who might have find themselves in a difficult or challenging situation, to continue the role of the association and strive to raise the level of clinical awareness on topical issues by providing quality CMEs for its membership. As you're aware, the foundation is the major fundraising arm for charity for the MAJ, and it is on a drive to garner funds to carry out its mandate. Its mandate is to provide invaluable financial assistance to memberships who from time to time will be in need of that. This is indeed a worthy cause. Colleagues, I appeal to you to support efforts of the foundation in achieving its desired goals by registering for the CMEs. The association and the foundation is indeed very appreciative of your support in attending this evening's webinar in order that the aims of the foundation can be achieved. Thank you, and over to you, Dr. Sophie.
Okay, thank you, Dr. Gordon. So we'll go right ahead with Dr. ALVERSTON Bailey. I just introduced him. He has so many credentials. I'll just try to summarize. Dr. Bailey is a graduate of UE, Jamaica, and he's been well known for his long career in occupational medicine for about 40 years. He's been Chief Medical Officer at Kaiser Jamaica Bauxite Company, as well as at UTech, where I work. He established a new program, academic program related, which was called the Bachelor of Science in Occupational Health and Safety and Environmental Management. He's also been very heavily involved with diabetes, and he was co-chair, or since 2008, has been co-chair of the University Diabetes Outreach Program, UDOP, and has been a spokesperson on diabetes-related issues, as well as a sought-after commentator on public health. And many people know he's an author of many academic papers, both here and abroad, and he's also has authored a book called Sexplanation. Sounds very interesting. So his career has really been very dedicated to health promotion, volunteerism, and he's really worked very closely with the Diabetes Association. And currently, since 2016, he's been an associate lecturer at the Caribbean School of Medical Sciences and was also appointed executive vice dean there in July 2023. So welcome, Dr. Bailey, and we know that you're going to speak to us about non-communicable diseases and sexuality. and circumventing the obstacles that come with that combination. So thank you very much. We look forward to hearing from you.
Thank you very much, Doc. In fact, before I make my presentation, I was actually invited to bring greetings from the AIKEN Foundation, so I'll just do that. I'd like to thank you, Madam Chair, for your kind introduction, and to all my fellow presenters, and to the President of the GP Association. And I'd like to thank all those who are online who have decided to join us in this venture. I was appointed to the post as chairman of the AIKEN Trust in 2018, and I'm really honored to have been entrusted with the task of renewing the trust mandate and enabling the trust to recalibrate its strategic plan, which would inure to the benefit of the members of the AIKEN. The trust was launched in grand style in 1994 during the presidency of Dr. Margaret Green. And the distinguished guest speaker at the time was Professor Dr. Mamphela Ramphele, Deputy Vice Chancellor, University of Cape Town in South Africa. On that memorable occasion, she congratulated the AIKEN for launching the AIKEN Trust. And she said, and I quote, "It offers you an opportunity to contribute to the development of a new professional ethos which goes beyond the individual whilst fully acknowledging the importance and dignity of the individual person. You stand on the threshold of exciting possibilities. The metaphor of standing at the threshold is an important one to reflect on for a minute. It means you can look back with pride on your past achievements, but also forward and outwards with a hope for a better tomorrow. 30 years later, colleagues, we have indeed progressed to a better tomorrow. And I'm pleased to inform you that we received approval for name change on October 19, 2022, and we are now designated as the Medical Association of Jamaica Foundation. Our primary mission is to ensure that all incapacitated AIKEN members with material needs who apply to the foundation are offered support and assistance. We therefore pledge to provide assistance to approved applicants to a maximum of 10% of our asset base annually. And I'd like you to know that for the period January 2023 to January 2024, we have assisted 3 colleagues so far with over $500,000. But you must be reminded that our asset base determines our ability to expand the scope of assistance. We are therefore encouraging you all to assist us in this endeavor and pledge a donation by visiting the AIKEN website and choosing an option that you prefer. Your contribution to this fundraising effort is greatly appreciated. And this evening's activity is a first for this year, and I'm sure you'll find this seminar intellectually quite gratifying. I'll now move on to my presentation. My presentation is about sexuality and NCDs. As the moderator mentioned, in collaboration with my friend and colleague, Dr. Carpenter, I penned a book in 2014 called Sexplanation, which I'd really encourage you to get a copy of and read it. The objective of this lecture is to introduce to you the concept of sexuality, to review quickly the sexual response cycle, discuss sexual disorders, and then we'll zoom in on the impact of NCDs on human sexuality. And then I'll be brave to venture in a fairly simplistic way into the area of sexual counseling, which Dr. Carpenter will elaborate on. Now, sexual functioning is a complex process that depends on the neurologic, vascular, and endocrine system, and is influenced by many factors, such as family and religious background, the sexual partner, and individual factors such as self-concept and self-esteem. But sexuality can be altered by a number of other issues. It can be altered by aging, life experiences, like example, abuse, various illnesses and their treatments. What is sex? This is a highly controversial topic, but sex usually refers to the biological characteristic that define humans as males or females. While these sets of biological characteristics are not mutually exclusive, as there are individuals who possess both, they tend to differentiate humans as males and females. It encompasses sex, gender identity and roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. Sexuality is expressed and experienced in thoughts, in fantasies, in desires, in beliefs, and in attitudes. It's also experienced and expressed in values, in behaviors, in practices, in roles, and relationships. It is, however, influenced by the interaction of the biological, psychological, social, and economic factors. Sexuality is also influenced by political, cultural, legal, historical, and religious and spiritual factors. And that is from the WHO 2006. I want to just remind you about the sexual response cycle. It involves a number of phases. It involves desire, excitement, orgasm, and resolution. I'd like you to look at the right slide, and it shows you that women have a capability to have multiple orgasms, as distinct from men who tend to have single orgasm with each episode. Desire, excitement, orgasm, and resolution. Excitement in men involves the penis becoming erect, the scrotal skin tightens, and the testicles enlarge and elevate. In women, it involves the clitoral glands and shaft increasing in size, and labia minora increases in size. In the plateau phase, the testes become elevated and engorged when orgasm is imminent, and the corpus gland release a fluid. In women, the clitoral glands retract on the clitoral hood, the clitoris becomes erect, and the labia minora darken in color. In the orgasmic phase in men, there are contractions of the muscles around the base of the penis. The semen builds up in the urethral bulb. There are contractions of the penile urethra, and semen is forced out through the urethra. In women, the clitoris remains retracted onto the hood. The uterus and pelvic muscles contract. And then there's resolution, where erection loss begins, and the penis returns to its previous state, and the testicles descend. In women, the clitoris returns to the unaroused state. The labia minora and labia majora return to their unaroused state and color. So let us now take a look at what can go wrong, so-called sexual disorders. Let's just take a look at female sexual dysfunction. This is coming from DSM-5, which describes female sexual interest arousal disorder, female orgasmic disorder, pelvic pain disorder. And it includes in women female hypoactive sexual disorder and female arousal disorder, and dyspareunia, which is painful intercourse, and vaginismus, which is spasm of the outer third of the vagina that interferes with intercourse. With respect to men, I'll go straight to men. And the sexual disorders that are seen in men are desire disorders. And the example of that is the male hypoactive sexual desire disorder, arousal, which is erectile disorder, orgasm, which is delayed ejaculation or premature ejaculation. Pain is quite uncommon in men. I want to spend a little while looking at male sexual disorder because this is the one that most of us tend to grapple with in our practice. The male hypoactive sexual desire disorder is described as persistent or recurring deficit sexual thought or fantasies and desire for sexual activity. The judgment of deficiency is made by the doctor, taking into account factors that affect sexual functioning, such as age and the context of the person's life. However, I wanted to focus on bullet number 3. The DSM-5 insists that the symptoms should have persisted for a minimum of approximately 6 months and cause significant distress. The point I'm making here, if an individual has what they deem to be a sexual disorder for a month or 2 or a few weeks, it would not be described as a disorder, and it must cause distress. The sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress, and I want to emphasize that because that is moving into Dr. Carpenter's domain. It is not as a consequence of severe relationship distress, because in many instances, the disorder is only confined to a particular relationship. And it is not attributable to the effects of a substance, medication, or a medical condition. I want to let us pause at premature ejaculation, because this tends to create a lot of confusion among both patients and doctors. And DSM-5 describes it as persistent, and I want to use the word persistent, or recurrent pattern of ejaculation occurring within 1 minute following vaginal penetration before the person wishes it. I want to emphasize this point because if the female wishes ejaculation less than a minute, or if the male wishes ejaculation less than a minute, then that's perfectly okay as far as I'm concerned. The symptoms should have been present for at least 6 months. And look at bullet number 3. Must be experienced on almost all occasions and cause clinically significant distress. If the female partner is perfectly happy for a partner to ejaculate under a minute, and the male partner is perfectly happy to do the same, then that does not bother me. Erectile disorder is difficult to achieve or maintain an erection. However, sexual desire is usually intact and is the most common problem for which men seek treatment, and the prevalence increases with age. And 60% of men over 60 experience erectile dysfunction. Let us now move into the main event, which is the impact of non-communicable diseases on human sexuality. The NCDs that we're familiar with are non-contagious. They have multiple risk factors. They have a long latency period. They have a prolonged course. And it results in functional impairment or disability, and in most cases are incurable. I'd also like you to note that all my slides cite the evidence which I'm using for this lecture. NCDs are responsible for over 41 million deaths each year, a figure that is equivalent to 74% of all deaths globally. So it's a serious problem. The dominant NCDs are cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes mellitus. And this slide summarizes that quite nicely. The other NCDs that we tend not to pay particular attention to, but I must bring to your attention, are the neurologic and mental diseases, example, Alzheimer's and dementia, Parkinson's disease, depressive disorders, substance use disorders and schizophrenia, glaucoma and hearing loss, digestive disorders like peptic ulcer disease, and inflammatory bowel disease. Musculoskeletal diseases like rheumatoid arthritis, osteoporosis, gout, back pain and trauma, and chronic kidney disease all impact on sexuality. I thought I'd just like you to be reminded that NCDs in Jamaica is very prevalent, with hypertension in the JHLS2 data in 2007 to 2008 being roughly 25% of the population, obesity 25%, hypercholesterolemia 12%, and diabetes 8%. Asthma 6.9%. This other slide, I think, is quite interesting because it shows that the primary population that seems to be affected by NCDs in Jamaica are female, and that's not good, especially with respect to obesity and hypercholesterolemia. So we need to bear that in mind. Let us now look at some of the NCDs and human sexuality. Let's look at cardiovascular diseases. The literature indicates that a high prevalence of SD exists among men and women with CVDs. The physiological changes in sexual satisfaction, such as erectile dysfunction in men and sexual arousal in women, are correlated with CAD severity. In certain studies, men with severe CAD, i.e. 2 or more occluded coronary vessels, had the most difficulty attaining and maintaining penile erection compared with men with only 1 vessel occlusion. I just want to point out something quickly to you, that diabetes, age, and hypertension actually increase ADMA, which is an asymmetric dimethyl arginine, which causes a decrease in nitric oxide, which results in endothelial-dependent disorder. This other slide, I think, is really nice because it shows that hypertension, dyslipidemia, and diabetes causes atherosclerosis and also impaired endothelium-dependent relaxation, resulting in arterial stenosis and impaired vasodilation. It's also important to note that age plays a factor because there's smooth muscle atrophy of the trabeculae and impaired relaxation, resulting in penile disorder. This particular slide, however, I think is one of the most important ones I want to share with you, which shows clearly that risk factors such as aging, hypertension, diabetes, smoking, hypercholesterolemia, obesity, and sedentary lifestyle causes progressive erectile dysfunction. And interestingly, at the onset of ED, 2 to 5 years later, the evidence shows clearly that these persons are at risk of clinical events such as myocardial infarction, stroke, PAD, and death. So erectile dysfunction is seen in 40% of men with hypertension. I want to emphasize again that chronic cardiovascular disease may be related to pre- or post-sexual symptoms such as erectile dysfunction in men and vaginal dryness in women that appear 1 to 3 years before angina. Among women with heart disease, 25 to 63% reported decreased libido, vaginal dryness, dyspareunia, decreased genital sensation, and decreased orgasm. The prevalence of these disorders in men and women with cardiovascular disease is estimated to be twice more common than the general population. This is my favorite slide. This was a study that was done by Davey et al. And published in 1997. It said sex and death, are they related? And if there's any take-home point I want you to bear in mind, you remember this slide. You can actually take a picture of it. It says that the death rate among the individuals with more orgasms was reported to be about 50% less than ones with lesser orgasm. Take a snapshot of this and look up the study. Fascinating stuff. Diabetes. As I mentioned, diabetes impact the nitric oxide pathway and cause endothelial dysfunction. And it has been shown that sexual dysfunction is common in patients with diabetes mellitus due to vascular, neurologic, and hormonal alterations. And most importantly, the alteration of the endothelium-dependent neurogenic relaxation. Neuropathy is likely to be an important cause of ED, and there's no clear relationship between the physiological decrease in hormones and sexual dysfunction, but the findings suggest that hypogonadism, testosterone replacement therapy, and raised prolactin level are associated with decreased libido in both sexes and ejaculation and erectile dysfunction in men. Erectile dysfunction, therefore, has been shown to occur in 50% of diabetic men under 60 years. And please make note of this, that these patients frequently report decreased libido, impaired ejaculation, and sexual dysfunction. And make a note that the evidence is cited below. In women, we tend to ignore this, colleagues. In women, diabetes causes frigidity, decreased libido, and feeling of inadequacy are common. Rockcliffe et al. Published that paper in 2003. Now, I thought this was particularly interesting because we tend to ignore this also. This paper actually stated that learning about the illness of the partner may lead to emotional shock. Psychological effect of the diagnosis of diabetes on the patient and the spouse and its impact on caregiver are said to be more severe than other illnesses. And this was a paper published in 2003 called The Association Between Diabetes and Mental Disorder. Let's move to urinary tract disease. Urinary tract disease can affect sexual activity too. Some of these diseases include chronic prostatitis in men and interstitial cystitis in women. Please note, colleagues, because a shot of this also, chronic prostatitis has been shown by multiple studies to be the second most common cause of premature ejaculation. Quella, McVeary, Whitmore, that's evidence. Interstitial cystitis is a chronic vascular condition that presents with frequency, urgency, suprapubic discomfort, and dyspareunia. Chronic kidney disease. The incidence of chronic kidney disease seems to be increasing in elderly people and is associated with physical impairment. The risk factors for chronic kidney disease are actually quite similar to cardiovascular disease: age, diabetes, hypertension, dyslipidemia, smoking, psychological problems, and anxiety. Interestingly, endocrine disorders are associated with CKD and can result in sexual dysfunction, decreased libido, erectile dysfunction, dysmenorrhea, and irregular menstrual cycles, and infertility. CKD also results in changes in prolactin, gonadotropins, and hormone levels, as well as vascular, neurologic, and psychiatric factors, and along the medical agents that are used can contribute to sexual dysfunction. It has been shown that serum testosterone level of men who are on dialysis is two-thirds less than the general population. The prevalence of erectile dysfunction is related to the stage of the disease, and at end-stage renal failure, it can be up to 80%. Quella and his team did a study and showed that there's a relationship between CKD and physical and sexual performance of menopausal women with coronary heart disease. Sexual function was also assessed using a sexual problem scale of the medical outcome study, and it was shown there was no significant relationship between GFR and the scale of psychological aspect of sexual function. But a survey done by Lou, Starowitz, and Gellert on sexual activity on hemodialysis patients confirmed the association between anxiety and depression and sexual dysfunction in patients. Now, this is one topic which we tend not to talk about, inflammatory bowel disease. This tends to be high among the elderly with sexual dysfunction. And the psychological issues with IBD are fear, worry, and anxiety, which can cause impaired sexual function. Crohn's disease and ulcerative colitis were shown by Andrews et al. That it causes psychological burden and impaired quality of life. And the symptoms include lack of sexual desire and decreased sexuality in 75% of men and 44% of women. That's quite significant. Erectile dysfunction in men and depression in both are the main problems that we see in inflammatory bowel disease. In fact, what they found was patients with inflammatory bowel disease often show reluctance to have sex because of disease symptoms such as flatulence and fecal urgency or fear of it and fatigue. What about rheumatic disease? We tend to ignore this also. Addressing the sexuality of patients with arthritis is often overlooked. All types of arthritis can interfere with daily activity. In this context, sexuality is one of the most important activities that is neglected. Tiredness, pain, motor restriction, depression, and loss of self-esteem all have a negative effect on sexuality. Several studies have been shown that 70 to 85% of people over 55 have osteoarthritis. And this was an interesting study. About 2/3 of patients with osteoarthritis develop sexual problems. 2/3 of patients with arthritis develop sexual problems, while 50% of people with rheumatoid arthritis experience decreased sexual desire. And 60% of them were not satisfied with the quality of their sex life. Van Barle and his team found that motivation, sexual activity, satisfaction, and problem of women and men with rheumatoid arthritis with healthy ones in a control group demonstrate a serious correlation between physical aspect of the illness and sexual dysfunction in these patients. The sexual desire and sexual fantasies were less in the control group. In another study, aimed to assess clinical and psychological determinants of sexual disability and unsatisfaction in women with rheumatoid arthritis, indicated that about 60% of the female participants reported having trouble in sexual relationship. And please note bullet number 2. Among them, 17% were unable due to severe arthritis to have intercourse, and 46% of the cases reported decreased libido and lack of sexual desire. Studies on sex concern of patients with RA revealed that reactivation of latent disease could negatively affect sexual acceptance due to depression and reduced self-esteem. Chronic lung disease. Chronic obstructive lung disease and lung cancer are the common progressive lung conditions that are strongly associated with limitation in physical functioning. And the symptoms of these diseases would include dyspnea, fatigue, anorexia, and malnutrition. Please note that sexual dysfunction is highly prevalent among persons with COPD. And problem with sexual function can negatively affect sexual satisfaction in these patients. In a study by Captain et al., male patients, and I would like you to pause note this, male patients reported that they did not, and I repeat, did not discuss their sexual concerns with their physicians, 87%, and almost 80% did not discuss their sexual problem with their partner. And that was, and sexuality therefore is a topic that has rarely been studied in patients with erectile dysfunction following COPD. Cancer will be discussed by Dr. AIKEN shortly, therefore I'll not get into that. And so I end my presentation by briefly talking about sexual counseling. What can doctors do? We need to change our attitude. We need to promote inquiry and discussion about sex and relationships with chronically ill patients. Entrenched negative attitude must change, and myths and stereotypes must be rejected. The following beliefs provide a foundation for more constructive perspective. We need to recognize that sex and relationships are important aspects of health. It is the doctor's role, therefore, to address quality of life issues, including sexual health. We need to acquire knowledge. Doctors need to acquire basic knowledge about sexual function and dysfunction, and the impact of illness and medication on sexual relations. We as doctors need to know how to open up the topic of sex for discussion and provide help to patients and their partners using a simple plan. And this is a implicit model. I'd like you to just screenshot this. It's a very interesting concept which you can go online and look up. It involves giving patients permission to raise sexual issues, giving patients limited information about sexual side effects of treatments, making specific suggestions based on a full evaluation of presenting problems, and referring to intensive therapy such as psychologists, sex therapists, or biomedical approaches. Therefore, I just want to end this discussion by reminding you that sexual counseling is very important in your practice, and the primary area I want to focus on is cardiovascular disease. Participating in regular sports activity is the most important principle, and successful resumption of sexual activity in patients with heart disease should be encouraged. Exercises in the rehabilitation of heart patients will increase heart rate, will decrease it during sexual activity, and reduce the risk of having a heart attack during sexual intercourse. Physical exercise improves erectile function in men and positively affects the man and his partner's desire for having sex. For aged patients, we recommend that they will be referred for sexual counseling, like group therapy. For persons with urinary tract infection, we recommend that they receive treatment for chronic prostatitis and ensure that those with chronic kidney disease are appropriately treated. For patients with rheumatic disease, please be gentle with them. Please remember that their joints might not be as fluid as they used to be, and it can impact with sexual desire and satisfaction. Therefore, treat them gently and advise them about different sexual positions that could help them. For those with chronic lung disease, you must remember that and coughing will decrease their physical activity levels, and therefore they should be advised how best to enjoy intercourse. Finally, there are many screening tools available which you can use, and I'd just like you to take a screenshot of that to remind you of the multiple screening tools that can be used in order to assess sexual desire, determine sexual arousal desire, determine orgasmic desire, determine sexual distress, and overall rating of sexuality. In conclusion, as doctors, we are most likely to be involved at the permission level when it comes to broaching the subject of sex. Active screening for sexual concern must be considered an essential part of the routine workup for any patient who suffers from a chronic illness, regardless of his or her age. This level not only gives the patient permission to talk about sex, but also seeks the patient's consent to explore this intimate topic. Doctors need to be respectful if patients decline this opportunity or limit information gathering because of cultural or other taboos. Seeing the patient as well as the patient, seeing the partner rather, as well as the patient can be very helpful. Questions about sexual issues are more comfortable for both doctor and patient when the patient understands the relevance of such questions to his or her situation. The relevance can be demonstrated and discussion encouraged in 2 simple steps. Embed questions about sexual function in an appropriate context by making a statement that links the patient, his or her medical history, with the disease and sexual difficulty. Ask an open-ended question. These questions can begin with how or what and invite a more discursive answer than just yes or no. For example, people with chronic renal failure often experience difficulties such as loss of desire or problems with enjoyment. Have you been affected? How is your health affecting your relationship? If we follow these guidelines, we'll be well on the way to becoming experts at addressing sexual disorders and non-communicable diseases. My references were obtained from these sources, and I thank you. And let me remind you to please purchase my book available online from Amazon. It's Sexplanation, a guide to discussing sex and sexuality in the Caribbean by yours truly. Thank you very much for listening.
Thank you so much, Dr. Bailey. I know I learned a lot. A lot. One doctor commented, "Good day, Dr. Bailey. Please send your presentation because you're moving at the speed of light." Well, that was funny. But at least you're moving well. So I think it was a good pace. Very interesting topic and very very good. But I'm not sure I'm seeing any questions yet in the Q&A. I don't know if anybody, or if you had any more comments, Dr. Bailey, or if anybody wants to put anything now in the Q&A. We have 5 minutes for that.
Yeah, in fact, because of the limited time, this particular topic actually needs a seminar, a whole day seminar, and Dr. Carpenter would agree. It's difficult to explain all the challenges that persons with non-communicable disease have in 25 minutes. The key point I wanted to make is that many doctors are uncomfortable with discussing sex and sexuality with their patient. And so I'm very pleased that the Agpj and the foundation has thought it fit to have a discussion, to start the discussion on this topic. We could have a seminar that just looks at sexuality in all its details. But this particular paper just meant to whet your appetite. That hypertension, diabetes, cancers, COPD, and arthritis in particular. A lot of patients with arthritis are disabled and cannot function properly. And persons with prostatitis. A lot of my patients have prostatitis and benign prostatic hypertrophy and do not discuss sex with me because they're embarrassed. So you really perhaps ought to begin the whole process of modifying your attitude so that you can broach the subject with patients so that they feel comfortable in sharing with it. Women in particular rarely ever discuss sexual problems. And what we have discussed just now is that diabetes in particular does impact negatively on female sexuality. And if the topic is broached, women will be more than happy to discuss it. So therefore, feel free to broach the topic gently with patients and inform yourselves about human sexuality and all its complexities, and you'll be far more comfortable in dealing with this matter.
Thank you, Dr. Bailey. And I think I'm still not, there are a few questions. Let me quickly look to see if maybe we could take one just to keep on time. So Dr. Bailey, if the ones that I don't pick, I don't know if you were willing to type an answer for them. I see 3 questions. I'm just going to pick one for time's sake. Let me see if I can pick. Okay.
I'd love if we could ask the Carla Hamilton one.
Okay. Well, all right.
I think Dr. Carpenter saw it and she smiled.
Okay. Well, I'll go with, okay. I wasn't going to choose that one, but anyhow. Carla Hamilton asked, is it true that a person's vagina locks up or gets smaller during menopause?
Locks up or gets smaller. No, in fact, it's a question that I could share with Dr. Carpenter, but the truth is that the older women get, in many instances, the better they get sexually. The vagina doesn't lock up at menopause. If the person suffers from vaginismus, it usually will occur fairly early in their sexual experiences. So if the woman experiences pain during intercourse after menopause, oftentimes it is due to a physical problem like vaginal dryness, or it could be because of atrophy. Now, the vagina does undergo changes with menopause, and so the lining tends to get thinner, and so the vagina is more prone to bruising. What I think is happening here is that because the female might experience some discomfort during intercourse, she might get some vaginal spasm, which is an expression of discomfort. And so if she starts experiencing discomfort after menopause, we need to look to it's hardly likely to be a psychological problem. It's most like a physical problem that could be addressed by a gynecologist or a sufficiently learned general practitioner to minimize discomfort by providing guidance in terms of lubrication or perhaps hormone therapy to enhance the basal cells of the vagina. So no, menopause doesn't impact on your sexuality at all. If you're sexually active pre-menopause, you'll continue post-menopause. So therefore, there's no fear that menopause has that kind of sexual dysfunction.
Thanks, Dr. Bailey. There are two other good questions, though, and I would ask that if you don't mind, while the other speakers presenting, if you have the time, if you could answer them, because there are questions, for example, about screening, cardiovascular screening with men with ED, which is a very good question, and use of Viagra and Cialis in persons with hypertensive heart disease and ischemic heart disease. And so another question regarding circumcision. So if you'd be so gracious as to answer, we'd appreciate that. And in the interim, I'll go ahead and go on to the next speaker. That's okay. So I'm going to introduce Dr. Jacqueline Campbell, who I remember well from medical school and then from family medicine. She's a UE graduate, both a family physician and a pharmacologist, and she holds both a Master of Philosophy and a Doctor of Philosophy degrees in pharmacology, as well as a certification in project management. What I know of also is not written in her bio data, but I know she's a lecturer and is quite knowledgeable on alternative medicine therapy for patients. And I know she incorporates it in her general practice, which is great. And not many, physicians do that. She's also the host of the radio program Powering Your Health, as well as a newspaper columnist, writing medically related articles, and also the author of a book, like Dr. Bailey. Her book is A Patient's Guide to the Treatment of Diabetes Mellitus. And on a more social side, she's a volunteer physician with the Women's Health Network, which is great to know. And she's an avid gardener. Great, not so surprised, and a certified bookaholic. Welcome, Dr. Campbell. We look forward to your presentation. Thank you for being here.
Thank you, Madam Chair. Thanks to the organizers. Sam, you know me. What do I need to do now?
All right, Doc. So we want to first open your presentation.
It's open, yes.
Go to presenter view.
All right, let me go in.
Right.
I had it here. Oh, golly gosh.
It's all right. So you just want to start the
Yes,
presentation so that it's up.
Yes,
And then remember, you're just going to hold the Alt key and then press the tab button for me.
yes.
Nice. Share screen.
And then share screen now. portion of
Advan
screen. Yes, and then share. This is it, right?
like a pro.
Almost a pro. Good evening, colleagues. Thanks to the organizers for inviting me to present on this very interesting topic, prescription drugs and adverse sexual effects. I should point out that Dr. Bailey had started the first part of my presentation. Some of it has been covered by Dr. Bailey. But I want to point out to you here that sexual dysfunction is a common unwanted effect of many types of drug therapy. And we already know that it's a multifactorial problem. It has psychological, biological, social ramifications. No, different drugs affect sexual functions in different ways, and this will be dependent on the mechanism of action of the drug. And it's important for us to have an appreciation of the normal biology of sexual function, so it can actually allow us to predict whether a particular medication may cause sexual problems. Now, Dr. Bailey had mentioned the sexual response cycle. So I found this diagram from Masters and Johnson. I found it very interesting. And in terms of the stages of the sexual response cycle, we should point out to you here that sexual interest, libido, is mediated primarily by the central nervous system. Arousal by the CNS, yes, and the parasympathetic nervous system. There's plateau, as we know, and then there's orgasm and ejaculation. These would be mediated by the central nervous system and the parasympathetic nervous system. And then there is a resolution. This is really a reminder slide about what happens in terms of men and also female. Now, when we look normal sexual functioning, we already know that it requires some ability to interact with others, and it also requires a variety of substances that are produced by the body. For example, it requires neurotransmitters, central neurotransmitters, peripheral neurotransmitters. For example, nitric oxide, which Dr. Bailey spoke about, hormones, neuropeptides. So all of these come together to promote normal sexual reactions, I should say. So let us get into the actual presentation. I found this definition, it's really DSM-4, our definition of and criteria for sexual dysfunction associated with medications. And it reads here, a substance-induced sexual dysfunction due to a prescribed treatment for a mental disorder or general medical condition must have its onset while the person is receiving the medication. For example, antihypertensive medications. Now, once the treatment is discontinued, the sexual dysfunction will remit within a few days, usually, to let us say several weeks. If the dysfunction persists, other causes for the dysfunction need to be considered. So let us begin first with antihypertensive drugs, because the fact is that 1 in 3 individuals in our country is hypertensive. And erectile dysfunction, so we're going to start with erectile dysfunction. It has, as it says here, a high prevalence in individuals with multiple cardiovascular risk factors and those with, of course, cardiovascular disease. And when we look at hypertension, it's considered to be one of the most hazardous risk factors, and is a frequent comorbidity in men with erectile dysfunction. Now, the prevalence of erectile dysfunction is higher in hypertensive men than in normotensive men. And the fact is that what we all know is that the deterioration of sexual function, which is due to antihypertensive drug therapy, can contribute to poor quality of life, and consequently, what we see happening frequently, non-compliance with therapy. So I found this very nice table, and let us begin with the beta blockers. So the association between beta blockers and erectile dysfunction is, I should say, we say well established, and in most studies that compared beta blockers and other antihypertensive agents, the non-selective beta blockers, for example, propranolol, were likely, or I should say more likely, to result in erectile dysfunction in comparison to the cardioselective one. So the cardioselective beta blockers would be atenolol, bisoprolol, metoprolol, and of course we know about nebivolol. And the non-selective beta blockers have a high potential to cause erectile dysfunction. Forgive me if I get pharmacologically here, because of what we call the resultant vasoconstriction within the cavernosal arteries. So if we remember from our pharmacology, vasoconstriction would be mediated by the alpha receptors. Anyway, moving right along there. Now, when we look at found this study, I found it to be particularly interesting, whereby they were looking at the adverse reactions to benzoyl, which is a thiazide diuretic, and propranolol. And what it reinforces what I just said, that the results from this study, it's an old study from 1981, but it showed that impotence occurred more frequently in those persons taking propranolol than in those taking the placebo. So let us now look at drug which I mentioned before, which is nebivolol. It's available in Jamaica. I checked it today. I called the pharmacy. Is this available? And the pharmacy said, yes, it is. And it was almost as if the pharmacist was giving me the lecture or delivering the lecture. So nebivolol is a third generation beta blocker. It's one of the cardioselective ones. So in other words, it has greater specificity or selectivity for the beta 1 receptors, and it works through nitric oxide. Now, interestingly, there was a study which compared atenolol, metoprolol, bisoprolol with nebivolol, and what that study showed is that switching from any of the other beta blockers like atenolol, metoprolol, bisoprolol to nebivolol resulted in improved erectile function in 69% of the patients that complained of erectile dysfunction with their original antihypertensive medication. There was an Italian study of 96 hypertensive men, and this study investigated the value of the placebo effect in beta blocker induced erectile dysfunction. So the men were divided into 3 groups. I'll be very brief with this one. The 3 groups. So in the first group, patients were blinded against the drug. Second group, patients were told that they were taking a beta blocker. They were being given a beta blocker, but they were not told of any of the adverse effects. In the third group, they were told that they were getting a beta blocker, and they were informed of the adverse effects of the drug on erectile dysfunction. So when they checked them 3 months later, guess what? The incidence of erectile dysfunction in the first group was 3.1%. The second group, 15.6%. The third group, that is the group where the men were actually told that they were getting a beta blocker and they were informed of the adverse effect, well, that group was 31.2%. So the study concluded that knowledge of the adverse effects of beta blocker can actually produce anxiety, which may lead to erectile dysfunction. So that was an interesting study. So we go back to the same table I was showing you before. So we're looking at the diuretics. Now, there is, just looking at this table, you will see that there's some lack of consensus on how the thiazide diuretics affect erectile dysfunction. You see all of these mechanisms of action. And there is ample evidence suggesting that they cause erectile dysfunction. When we look at the potassium-sparing diuretics, so in terms of this potassium-sparing diuretics, remember you have two classes, spironolactone, eplerenone, and then you have amiloride and triamterene. Now, spironolactone and eplerenone, these are antagonists of they're mineralocorticoid antagonists. And so they would have more of a systemic effect. And amiloride and triamterene, they act independently of aldosterone. So you'll find that within this particular class, the potassium-sparing diuretics, amiloride, triamterene would be the preferred agents within this particular class. Please remember, please note that with spironolactone, we can see the development of gynecomastia and of course painful breast enlargement in women. Loop diuretics tend to be have a pretty neutral effect on erectile dysfunction, and the studies have shown that they would be a preferred diuretic, as it were, in terms of the effect on erectile dysfunction. I should point out here, that many times we'll see something in one study and then you find another study which may contradict that. When we look now at the calcium channel blockers, and amlodipine, all of those, verapamil, they will induce vasodilation, and you'll find in general that they have a pretty neutral effect on erectile dysfunction. Now the next one would be ACE inhibitors and ARB, angiotensin receptor blockers. Going back to pharmacology class here. So love this diagram. So when we look at it, you have the ACE inhibitors. You will see that the ACE inhibitors, they are going to prevent the formation of angiotensin 2. So they are blocking the conversion of angiotensin 1 to angiotensin 2, and at the same time, they would be blocking the conversion of, or I should say the degradation of bradykinin. Now, the significance of this is that angiotensin 2 is a potent vasoconstrictor. So you're sort of blocking all of that there. So when we look at ACE inhibitors, I have the next slide to show you, but I'm going to talk about the ARBs first. The ARBs, here we are here. What they do is that they are going to be antagonizing the end organ effect of angiotensin 2. So what am I saying in English now? Now, it shows that with the ACE inhibitor, the decrease in angiotensin 2 And in addition to dilation of what is known as the cavernosal arteries, they cause prevention of what is known as the changes in the collagen in the corpora cavernosa. All of these mechanisms cause actually an improvement in erectile dysfunction. With the ARBs, you'll find too that they cause an increase in nitric oxide synthesis. So what I'm saying by all of that is that the ACE inhibitors and the ARBs tend to be beneficial in terms of the effects of erectile dysfunction. So we talk about erectile dysfunction. Somebody must be saying, so what about women? The fact is that sexual dysfunction is more common in women with hypertension before treatment compared to normotensive women, and sexual effects of antihypertensives are actually poorly studied in women. But these particular drugs, the antihypertensive drugs, may have similar adverse effects on the arousal phase as in men. And of course, if they have the same effect on the arousal phase, what we're going to see happening would be failure of vaginal wall swelling and, of course, lubrication. Of note is the fact that the alpha adrenergic drugs like clonidine and prazosin can cause a decrease in desire and arousal. Never forget, a few years ago, a patient come to me. She was a lady coming in from the US, and she said to me, "Look here, doctor, you have to change this drug." They put me on this in the States where she coming from. The drug was clonidine. She said, everything for me mash up. It mash up my sex life, dry me up. You have to change it. So me being a good physician, I change it to something else. Forget what I changed it to. And she was very happy when she came back a month or so later. Valsartan is associated with improved sexual desire and fantasies compared with atenolol in hypertensive women. Good thing is that valsartan is part of the drugs that many of us prescribe for our hypertensive patients. Now, the next slide is really to just highlight some of the other drugs, which would be some of the other cardiovascular drugs, which could be associated with sexual dysfunction. So clonidine, which I spoke about, yes, digoxin, hydrochlorothiazide, diuretic there, methyl dopa. Well, methyl dopa is not used so often now, mainly in hypertensive pregnant women. Also the beta blockers there. Perhexylene, that is a prophylactic anti-anginal drug used mainly, let us say, in New Zealand and Australia. And of course, we spoke about spironolactone. Next, we're looking at psychiatric and neurological drugs. Up to 70% of patients with depression have sexual dysfunction, and this can affect any phase of sexual activity. You will see the numbers here. Significant number of women and men with schizophrenia experience sexual problems. The point here is that in these patients, it may be difficult to distinguish the effects of the illness on sexual functioning from the effects of drugs used for treatment. And let us look at this particular slide here. What we're seeing here, drugs associated with sexual dysfunction. You have sexual desire, decreased desire, decreased arousal, orgasm or ejaculatory difficulties. Right across the board, we're seeing the TCAs, I'll just pick them out for you. Amitriptyline, clomipramine, imipramine there, with decreased desire, decreased arousal. Clomipramine with orgasm or ejaculatory difficulties. We see the SSRIs, fluoxetine and paroxetine, their decreased desire. Also, sertraline coming in with a decreased arousal, orgasm or ejaculatory difficulties. Paroxetine is there, fluoxetine, and these are, as I highlighted here, sertraline. They are common causes of orgasmic difficulty. But in general, if I had to summarize this, you'll find that the SSRIs and the SNRIs, which is a selective serotonin norepinephrine reuptake inhibitors, for example, venlafaxine, they inhibit desire, cause erectile dysfunction, and they can cause a decrease in vaginal lubrication. They also impair orgasm in up to 71% of patients. But somebody is saying, the fact is that this particular adverse effect can be used therapeutically to delay premature ejaculation. Yes, so that is why patients would some people will approach you and say, Doc, you can give me some anafranil, or some persons, that's the brand name for clomipramine, or some persons will specifically say that, you know what, when they take sertraline, or let us say paroxetine or fluoxetine, they find that there's an improvement in terms of their sexual functioning. So you can use adverse effects to benefit persons. Now we're looking now at the effects of antidepressants on erectile dysfunction. So we had looked on just in general here. So this is just another way of looking at it. So we see again the antidepressants, the SSRIs, the SNRIs, the tricyclics, monoamine oxidase inhibitors, phenazine. Hardly use those anymore, but they are in use. And so they have a strong association with erectile dysfunction. Those that have a minimal effect on erectile dysfunction would be bupropion, which we know is a really good antidepressant and is also useful in smoking cessation. Moclobemide, mitrazapine, all of those, they're not really used so much in Jamaica. The next group that I want to look on would be the antipsychotics. So here, interesting slide, we're looking at the effects of the antipsychotics on erectile dysfunction. Again, we're looking at strong association with erectile dysfunction, minimal effect on erectile dysfunction. Look in the red text box. Those that have a strong association with erectile dysfunction would be the first generation antipsychotics. There's an error in this slide in that clozapine is not a first generation antipsychotic. It is an atypical antipsychotic. But the point is made here that haloperidol, clozapine, thiazidine, and risperidone, which is an example of an atypical antipsychotic, these have a strong association with erectile dysfunction. All of the second generation antipsychotics, with the exception of risperidone, they have a minimal effect on erectile dysfunction. So we're talking about aripiprazole, quetiapine, all of those. This is going to be illustrated in the next slide. So the point I'm making is that some antipsychotics may affect sexual function more than others. So here we're looking at the relative impact of antipsychotic drugs on sexual functioning. Aripiprazole, quetiapine, clozapine there olanzapine, haloperidol, and risperidone. So those at the bottom would have the most impact on sexual function. When we look at antipsychotics, so you have the effect on men, effect on women there, the majority of the antipsychotics would be causing the sexual dysfunction by dopamine receptor blockade. So we're not into a pharmacology lecture per se, but if you remember that you have the D2 blockade for the typical antipsychotics, and the atypicals would act in different ways. So you're looking at that, and when you have dopamine receptor blockade, that can lead to hyperprolactinemia with suppression of the HPA axis, and of course this can lead to decreased sexual desire. It can also lead to an impairment of arousal and of interest in women. We know that that can cause secondary amenorrhea, loss of ovarian function, and of course, it can cause a low testosterone level in men. So this is what happens with the antipsychotics. We're looking now on anti-epileptic drugs. Sexual dysfunction is common in patients on anti-epileptic drugs. Again, we're looking at the strong association with erectile dysfunction, minimal effect on erectile dysfunction, and they're right here, phenytoin, all of the ones that are used as the neurologists would say, these would be the older, tend to be the older ones. The newer ones, I almost said the younger ones, the newer ones, lamotrigine, valproate, we have to watch that one. That's an older drug, causes problems in women. Gabapentin, the gabatrin, that's an old one, but these tend to have minimal effect on erectile dysfunction. Of note is the fact that gabapentin, topiramate, are associated with orgasmic dysfunction in men and women, and decreased libido in women. Again, note that topiramate is not just used in treatment of epilepsy. It can also be given to those persons who have are suffering from migraine headaches. Oral contraceptives, OCPs decrease circulating testosterone. We see here with Depo-Provera, which is depomedroxyprogesterone, that can cause, and we know, the weight gain, depression, vaginal atrophy, dyspareunia, and decreased libido in up to, it says here, 15% of women who are taking it. We're looking at treatments for cancer. Yeah. Now, the impact of malignancy and its treatment on both the patient and his or her partner can have a significant negative influence on their sexual relationship. And many of the cancer treatments can lead to sexual dysfunction. So let us
2 minutes left, Doc. 2 minutes left.
Treatment here. You have the long-acting gonadotropin releasing hormone agonists. They can cause reduction in sexual desire, vaginal atrophy, and dyspareunia. Their BPH, which Prof. AIKEN will speak about here. The drugs, steroids, immunosuppressive drugs, protease inhibitors, they can cause erectile dysfunction too. The other drugs I want to point out to you here, decreased arousal. You know that antihistamines can do that. Pseudoephedrine can do that. The NSAIDs, we could probably have a whole session, Dr. Bailey, on NSAIDs and what the effect that they could have on sexual function. Drugs interfering with hormones, tamoxifen, decreased libido, vaginal dryness, dyspareunia. How are we gonna manage this? Well, it's right here. In the interest of time, we can always talk about this in Q&A if necessary. Let me just summarize here. The influence of drugs on neurogenic, hormonal, vascular mechanisms may result in decreased libido, impotence, ejaculatory, and orgasmic difficulties, inhibited vaginal lubrication, gynecomastia. The drugs that affect libido centrally, they may reduce desire by causing sedation, hormonal disturbance. The drugs that interfere with the autonomic nervous system that can lead to effects on erectile function, ejaculation, and orgasm. And we know that the drugs interfering with hormones, for example, tamoxifen, can affect vaginal response. And usually, drug-induced adverse effects, they are reversible with discontinuation of the offending agent. The take-home message, sexual dysfunction is common. We need to initiate a conversation with our patients, as Dr. Bailey said in his presentation. These are my references. Thank you for your attention.
Thank you very much, Dr. Campbell. That was very enlightening. You know, it makes us almost not want to prescribe any drugs. But
It's actually a little bit scary, but you know, you have to really ask the patient,
right.
initiate, and you know, you have, like, for example, a patient of mine said to me, "Why doctors don't even think about these things?" Because some of us, she was talking about to her friend, and she said, "Boy, the friend said she dry like paper, and doctors not talking to her about what is happening." So many times, let us say someone who is premenopausal or menopausal may be experiencing vaginal dryness. So it could be due to the menopause itself, but it could be due to medications that this person has been taking for her, for whatever condition she has. So it's quite interesting and eye-opening.
It was. There are two questions in the chat. I'm going to choose one, and then you could, if you don't mind, typing the other one with the response of them. This one says, "A very good presentation, Dr. Campbell. I agree. Within recent times, a number of men have been complaining of reduced volumes of ejaculate, often associated with some level of anxiety, as their partners tend to comment. Would you place this under sexual dysfunction, and are there drugs that might be accounting for such?" I think that's a very good question.
I'd have to really think about that carefully. If I put it under sexual dysfunction, maybe Dr. Carpenter could help me with that one. But it could be, it is possible that it could be drug-induced. So if that is happening, what I would do is ask the person, "What drugs are you taking?" So have a conversation with the individual about the drugs that he's actually taking. That's what I would do.
Okay, I'll just ask this one more. It's a short one. This person says, "Thanks for an excellent presentation. Can you please speak on the drugs, both prescription and street drugs, that have hypersexual effects?" I think that's what they're asking.
Yes. You know, the one that the hypersexual effects would be the anti-Parkinson agents. Anything with dopamine, because you're increasing dopamine. Those are the ones. It's interesting that some of the street drugs, we can think of the poppers. You know, poppers.
Explain what those are.
The poppers would be like amyl nitrate. Amyl nitrate, that it comes into some little vials, and they could just pop it and they inhale. What that does is that it actually, mechanism would be that it increases the blood flow to the penis. So, and it actually enhances penile, it enhances erection, and it also relaxes anal sphincter. So what it actually does is that it can facilitate anal sex. Yes, that one for sure comes to mind.
Thank you very much for answering that. If you don't mind answering any other unanswered ones in the chat, we'd appreciate
I
it.
don't mind. I
Thank
don't
you
mind.
again. Okay.
You're welcome. Thank you.
I think that now, Sam, you can tell me if I'm right, but I think we have a sponsor presentation now by MedInpex. Is that so?
Sorry, I was muted. Yes, we now have a sponsor presentation by MedImpex, and we want to acknowledge Melanie Miller, who is here with us from MedImpex. So here we go.
Good evening, everyone. I am Melanie Miller from MedImpex Jamaica Limited. Today, I will be highlighting two very important products from the MedImpex portfolio. Let's dive right into the first one. So this is the Stimuloton, which is a sertraline molecule. Sertraline is a selective serotonin reuptake inhibitor, or SSRI, and these have become the first choice treatment for depression owing to their excellent efficacy, safety profile, side effect profile, and their onset of action. SSRIs act within the brain to increase the amount of neurotransmitter serotonin in the synaptic gap by inhibiting its reuptake. It is indicated for depression and obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, social anxiety disorder, and premature ejaculation. Let's touch a little more on sertraline for premature ejaculation. Sertraline works to delay ejaculation in a sort of roundabout way. It does help many men in the treatment of premature ejaculation. Sertraline does many things to the brain. It can help regulate mood in people with certain mood disorders. Sertraline does this by preventing the reuptake of the brain serotonin supply. Higher serotonin levels mean the brain has more of this neurotransmitter to regulate mood, and as a result, one can avoid the extreme highs and lows associated with mood disorders. Again, this is the dosing regime for Stimuloton, or sertraline, for premature ejaculation. It is an off-label indication, by the way, so it's 50 milligrams once daily for over a 6 weeks period, and then when needed thereafter. Therapeutic effects can be observed after a 4 weeks period. It can also be used as a prophylaxis, where 50 milligrams is given as needed at least 2 hours prior to sexual intercourse. These are some of the side effect profile of taking Stimuloton. It affects some persons in these ways, and some do not experience these sorts of side effect profiles. So Stimuloton comes as a pack with 30 film coated tablets, 50 milligrams. The cost from MedImpex is $3,480, and the Stimuloton is subsidized by NHF under depression and psychosis. Stimuloton is amongst the most potent SSRIs. It has no influence on sertraline clearance. Plasma levels and clearance can be quickly and effectively controlled. Smaller effect on the CYP enzymes, thus reducing drug interactions. These are some of the benefits of taking the Stimuloton. So for premature ejaculation, remember, Stimuloton will stimulate. Our next product is the Tamsul, which is a 0.4 milligrams tamsulosin. Tamsulosin is a peripherally acting alpha-1A adrenergic antagonist. Tamsulosin selectively blocks alpha-1A adrenal receptors in the prostate, leading to smooth muscle relaxation in the bladder neck and prostate. This results in improved urine flow and reduced BPH symptoms. The alpha-1A adrenergic receptors dominate in prostate stromal elements. Tamsulosin's affinity for alpha-1A receptor is 7 to 38 times greater than for alpha-1B, making it more uroselective than terazosin or doxazosine. Approximately 75% of the alpha-1A receptors in the prostate are of the alpha-1A subtype. Alpha-1 adrenergic receptors are members of the G protein-coupled receptor superfamily. Specific actions of the alpha-1 receptor mainly involves smooth muscle contraction. It causes vasoconstriction in many blood vessels, including those of the skin, the gastrointestinal system, the kidney, and the brain. Other areas of smooth muscle contraction are the ureter, urethral sphincter, the vas deferens, and others you can see on screen here. Tamsulosin has a very high protein binding with a half-life of 9 to 13 hours. It has a rapid onset of action, and there is more than 50% renal clearance in taking the tamsulosin. Tamsulosin is indicated for benign prostatic hypertrophy or hyperplasia, and this is the treatment regime: 0.4 milligrams once daily to be taken 30 minutes after meal each day, and it may be increased to 0.8 milligrams once daily after a 2 to 4 weeks period if inadequate response is observed. Also indicated for urethral stones. This is an off-label indication, by the way, so it facilitates kidney stone expulsion and stone size from 5 millimeters to 10 millimeters. Again, this is a dosing regime for persons who are using Tamsul for urethral stone expulsion. And it is also indicated for bladder outlet obstruction, which is also another off-label indication. It offers relief of symptoms for persons who are experiencing this. Here we have some of the adverse effects of Tamsul are for persons who are taking these. And Tamsul is contraindicated in patients known to be hypersensitive to tamsulosin, and also in patients should be screened before treatment and at intervals during treatment in order to rule out prostate cancer. Tamsul is a category B for pregnant women, though it is not generally recommended for use in women. It has been used successfully to treat kidney stones in women by relaxing the bladder muscles. No dosing adjustment is needed for renally impaired patient nor hepatic impaired patient. And these are some of the drug interactions of tamsulosin with other molecules. And the Tamsul is $1,900 from Medimpex. The pack size is 30, and these are 0.4 milligrams capsules. Tamsul is subsidized by NHF, and it can be found under the category of benign prostatic hyperplasia. Why Tamsul? Tamsul is an alpha-1A blocker, which is a common first-line agent for your BPH patients. It offers rapid symptom reduction. It is uroselective and specific to the prostate, less impact on blood pressure, and it is also cost effective. Thank you for your attention and your time. Have a good rest of the evening.
Thank you very much, Melanie, for your informative presentation. I'll go right ahead with introducing the next speaker. We made a little bit of a switch. So Dr. Carpenter is going to go before Professor AIKEN. So she's going to go now. And her topic is, well, sorry, let me introduce her first. Beg your pardon, Dr. Carpenter. Dr. Carpenter is the head of the Institute for Gender and Development Studies at UWI-Mono, and she's a licensed counseling psychologist here in Jamaica, as well as she's Florida board certified clinical sexologist. She's also the director of the Caribbean Sexuality Research Group Clinic at UWI. She has several books, including Love and Sex, the Basics, Questioning Caribbean Jewish Identity, Interweaving Tapestries of Sexuality and Culture and Language, Race and the Global Jamaican. And finally, she is the host of Love and Sex on Facebook. I haven't heard of Love and Sex. That's interesting. I will look it up. Welcome, Dr. Carpenter. And I think many of us are looking forward to your interesting topic, which I need to say again. It is sexual addiction online and offline, managing the risks. Thank you.
Thank you very much. In the interest of time, because I do know that we're running a little late, I'm going to not spend too much time on the slides that have information that my colleagues have already presented, because of course you will already have heard some of those things. I want us to focus very carefully on the issue of sexual addiction, because it's a term that's bandied about quite a bit, and I want us to have a full understanding of what actually is meant by sexual addiction and how it's being dealt with. In the overview, you see some of the areas that we're going to quickly touch on. I'll try to be as time efficient as possible. So we're going to have a look at what addiction is, what does sex have to do with addiction. The DSM has already been covered in part, and some of the categorizations we use to talk about sexual dysfunction. I have some 1-minute case studies, which perhaps might be useful, and I want to specifically zero in on PGD, PGGAS, persistent genital arousal disorder, persistent genital arousal syndrome, and look at the way forward. So hopefully this will be quick and lively, and you can get the information in quite easily. So sexual addiction, as defined in many of the sources that we find, and this is Cleveland Clinic, speaks to an intense focus on sexual fantasies, urges, or activities that can't be controlled. And I am doubtful about the can't be controlled, and which cause distress or harm to your health, relationships, career, or other aspects of your life. And that's quite important, because so many people come in to sex therapy and say, I have a sex addiction. And when you say to them, are you working? They say, yes. Do you have a partner or a family? Yes. Are you functioning well in those spheres? Yes. Do you have outside activities that you're interested in? Yes. Do you socialize? Yes. Well, if you have a so-called sexual addiction, you certainly wouldn't be functioning well in those areas. So when we talk about addiction, addiction is something that sets up a chemical response in the body. And while sex does have a chemical response related to orgasm, it is not a reliable response as you would get with a dosage of some kind of narcotic or other kind of drug. It's a very unpredictable dosage and a very unpredictable response, and that's why orgasms differ. So with the unpredictability of whether or not we are actually going to arrive at that dosing in the brain of the dopamine, the oxytocin, and the endorphins, it's unlikely that we become addicted to the chemicals that are released in the body due to an orgasm. But anyway, so you may hear healthcare professionals call this compulsive sexual behavior. Sexual addiction is a term most commonly used by lay persons, and you will notice that I've highlighted that. I will have a little caveat that I want to speak about. Healthcare professionals, especially sex therapists, do not, let me repeat, do not accept that there is something called sexual addiction. We've popularized this term without sufficient research and evidence that there is such a thing. Okay, but I will speak about the things that do exist. So we talk about compulsive behaviors, whether sexual or otherwise, problematic sexual behaviors, hypersexuality, and that's a touchy one, yes? And I think Dr. Bailey touched on, my very good colleague and someone I really enjoy presenting with because he adds so much value. to this issue of treating sexual dysfunction. Dr. Bailey mentioned at the top of the presentations that, in fact, if someone has early ejaculation and their partner is not unhappy with it, and they're not unhappy with it, then we don't treat it, because that kind of partnership in which both parties are satisfied doesn't experience distress. So the experiences distress is a very big part of a diagnostic criteria for the DSM. So hypersexuality, sexual compulsivity, sexual impulsivity, and I've highlighted impulsivity because what we talk about in sex therapy or clinical sexology is impulsivity, not addiction, because there's no addictive chemical property that we can reliably increase in dosage. You can't say to your partner, oh, I want double the orgasm I had the last time, and I need it within, 5 minutes of each other. I can't shoot up with an orgasm. Okay. Although sex addiction involves activities that can be common to a sex life, such as masturbation, pornography, phone sex, cybersex, multiple partnerships, and more, it's when your sexual thoughts and activities consume your life that you may be considered to have a sexual addiction. Precisely this caveat, which says, although sexual addiction involves activities that can be common to a sex life, this is precisely why we do not use the term sex addiction in therapy. Because what people report as sex addiction is often part of a sex life anyway. It's not something outside of the sex life, and invariably they're functioning well in society. So their proclivities may be giving them some difficulty psychologically. They may be concerned about their proclivities, but it does not mean that they're addicted to sex. Now, how did we come to this notion of sex addiction? Patrick Carnes is one of the persons who is quite single-handedly responsible for the notion of a sex addiction. Patrick Carnes comes out of a religious background. He is a counselor educator, and he has started what is called the International Center for Treating Sex Addiction. And Carnes developed a model, which is a very interesting and good model, but again, the term addiction is the issue that we have with it. Carnes began by treating, he was, this therapist to the stars. Now, remember, he's a counselor, educator, not a sex therapist. And through some of his more famous clients, his treatment model became very popular, and people started to flock to Carnes to be treated for addiction. And of course, if you were a megastar and you were cheating on your partner and it became public knowledge, and you were embarrassed and shamed by society for this, it would be great to say that you checked yourself into an addiction clinic for sex addiction. And so the model grew out of the kind of AA model, NA model, where you would go into rehab, and Carnes popularizes. He developed his model over time. Note that at the top right-hand corner of my screen, at least, where he says your core beliefs that cause your addiction, at the bottom of these core beliefs, not scientific at all, is God isn't good enough, doesn't love me enough, won't or isn't powerful enough to meet my needs. I don't know of any psychological, psychiatric disorder that has God in the diagnostic criteria. This is problematic. But this is where this sex addiction model became popularized. Some of what Carnes points to is quite useful. For instance, cycle of addiction, which already is quite useful and existed prior to the sex addiction notion. People who are suffering wounds, and certainly wounds of a nature that are often sexual, their belief system around sex, and their shame and guilt around sexual fantasies, etc., actually cause them to be preoccupied and obsessed with these fantasies. And there are a number of triggers that could initiate this fantasizing about sex. Then it becomes ritualized. So they have a set pattern that they use in order to deal with their compulsions. They act out in a particular way. They go into the shame and guilt cycle. They experience despair. And in order to get rid of that despair, they start all over again because they are wounded. It's interesting that Carnes's note about God isn't good enough, etc., that in my own work in 22 years, I've seen more people who are from a religious background, a deeply religious background, who come in and claim to have a sex addiction. So I suspect that in part when they self-diagnose, they are seeing sexual activity already as prohibitive. And so any sexual activity that they think is beyond the norm, they view that as an addiction. I put this in red on purpose. So is sex addiction or hypersexuality considered a mental health disorder? And the resounding answer is no, it is not a mental health disorder. The American Psychiatric Association rejected the proposal to include hypersexual disorder as a condition of the DSM-5, which is the latest version, the Diagnostic and Statistical Manual of Mental Disorders, and their manual for assessing and diagnosing mental health conditions. Their reason was lack of evidence and the potential consequences of calling excessive sexual activity a pathology. Calling it a disease or a disorder and calling it a pathology suggests that sex is inherently pathological. Again, I go back to Dr. Bailey's example, and I want to add to Dr. Bailey's early ejaculation example, the notion of desire discrepancy disorder. The most common disorder that sex therapists treat around the world is desire discrepancy disorder, which is not a disorder that stands on its own, but rather looks at whether or not partners within a relationship are sufficiently satisfied with the frequency of sex, the type of sex, and the meaning of sex that each of them holds. When partners are satisfied with the frequency of sexual activity, intercourse, outer course, and all the courses, when they are satisfied with what is on the menu, the types of sex they have, and when they're satisfied that for both of them, the meaning of sex is similar, they tend to be very sexually compatible and tend not to complain about a partner having excessive sexual desire or hypoactive, low sexual desire. These partners are not the ones that we see in our practice. The ones that we see are the ones who are not well matched sexually. And it's interesting that we want women to have a low sexual desire and men to have a high sexual desire to come together and have satisfactory sex. That's not going to happen. Yes? And men often talk about wanting a woman with a very high libido. Well, many men who say that actually, when they're faced with a woman with a high libido, are often shocked that a woman could want sex more than they could because of the cultural notions around sex. So how common is sexual addiction? How often are they diagnosing it in the United States, where it has become popularized? It appears in about 3 to 10% of the US population. It's more common in men than women because men have permission to speak about sexual hypersexuality and hyperactivity than do women. Women are not supposed to want sex, and women are supposed to be quiet about sex. So for every 2 to 5 males with hypersexuality, 1 woman is affected. This is what they have in their statistics at the moment. They say that sexual addiction begins in the United States on average about 18 years of age, and most individuals don't reach out for professional help until age 37. In the Caribbean and certainly in Jamaica, the age of initial sexual activity is an average of 15 years. So I'm not sure whether or not we might see a lower age at which people are talking about being sexually addicted than in perhaps the United States. Many individuals have a history of other mental health conditions. So if we look at our bipolar population, whichever of the bipolar 1, 2 disorders, you can find that when someone is in an episode, a bipolar episode, that they will intensify whatever activity it is that they are acting out with. And I have had clients who have acted out sexually during an episode, but you have clients who act out in gambling, who act out in many different ways, yes? And it's an impulse control issue that they're having. Anxiety disorders. I've been very, very surprised, and Dr. Bailey, we have to do a study on this. I'm throwing that out there, that I'm very surprised at the number of men who come in for therapy. And as I say, I've been doing this for 22 years in Jamaica. I'm surprised at the number of men who come in who have multiple partners, but also suffer from anxiety disorders. So I suspect that in this instance, they are unable to distinguish between the excitation, which is interpreted as anxiety, and the excitation, which is interpreted as arousal. And we know in psychology that these are almost identical physiologically. It is how we interpret it in the brain that creates the notion of anxiety or arousal. Very same sort of physiological responses. So I wonder about that with men who have multiple partners. Some personality disorders as well are obviously more easily predisposed to reporting hypersexuality. And impulse control disorders, that's a biggie here. That's what we are often looking at when someone says, I'm a sex addict or I'm addicted to sex. It is an inability to control impulses. And as again, this could attach to gambling, this could attach to any type of activity, but it also attaches to sex. Obsessive compulsive disorders, often they will be paired with that kind of hyperattention to sexuality, and then attention deficit hyperactivity disorder. Clearly, if you cannot stay on task for long, then it means that your mind is going to flit back and forth, and perhaps you'll use the fantasies and those kinds of sexual stimulation to keep your mind centered. We spoke about these. The previous two presenters already mentioned them, and the one that I would like us to look at is the final one at the bottom here, persistent genital arousal disorder. Persistent genital arousal disorder was first brought to our attention in sex therapy by Sandra Lieblum. Fantastic research out of the United States. So Lieblum and Rosen were the first ones to document in scientific journals the persistent genital arousal disorder. And here in Jamaica, I've actually met people who have persistent arousal disorder. So it's an impulse control disorder that we're labeling sex addiction. And this category applies to presentations in which symptoms are characteristic of disruptive behavior, behavior that the individual feels that they can't control. Some of them are conduct disorders, but here we're thinking more of impairment in social occupation, causing you clinical distress. They don't meet the full criteria of any of the other disorders that are disruptive, but it does cause you to behave in ways that are, in your mind, not controllable, right? So the individual usually experiences great distress. The unspecified disruptive impulse control and conduct disorder category is used in situations in which the clinician chooses not to specify the reason that the criteria are not met. So they use a more generalized kind of diagnosis. And impulse control and conduct disorders tend to go together. So we see some acting out, perhaps, in the same disorder. How we look at sexual disorders, sexual dysfunctions within sex therapy and clinical sexology is that we look at four main categories: our desire disorders. And if you looked at the sex cycle, you'll know that these are the four areas in which we move through the sex cycle: desire, arousal, orgasm, and then there are the pain disorders, and then we want resolution after we've become orgasmic. So those are the areas that we tend to look at, and there are subcategories under those. But when we hear a client coming in that says, oh, I think I'm a sex addict, or I have erectile dysfunction or some other issue, we're going to ask a couple of questions. We're going to ask 3 questions. Has this been ever since you began having sex or began being sexual? Because sometimes intercourse doesn't come first. Is this only happening in certain situations that you experience this? Or is this only with certain partners that you experience this? And I think Dr. Bailey hinted at that earlier. So it can be lifelong or generalized, the dysfunction, situational, only happens at certain times, or partner specific. I remember, as we go to the mini case studies, I remember a client who, whenever he was going to engage sexually, he would immediately get, an urgency around having to pee. And most of us know that you can't maintain an erection and pee at the same time. So he would get this urgency, he would go to the bathroom, he would or would not pee, but just the act of that urge, yes, incontinence, would send him to the bathroom, would reduce his erection, would make him gaining another erection almost impossible. And this plagued him throughout his adult life. Okay, so let's look at some mini case studies. 1 minute case studies. The man whose sex addiction was a sexual orientation, desire discrepancy disorder, the woman who came and came and came, which brings us back to persistent genital arousal disorder. A client came in some time ago, and the client had asked to come in because they thought they had a porn addiction. And the client went on at great length over a couple of sessions about this porn addiction. And I would ask, well, what sort of pornography are you watching? Oh, they watch everything, etc., etc., etc. And they went on unconvincingly, as far as I was concerned, about this porn addiction. And I simply asked the client, now that we've talked about porn for 2 sessions, we've really exhausted the porn issue. Is there something else you want to speak about? And the client said, well, actually, I think I'm addicted to having sex with men. The client did not say that they were homosexual. The client did not say that they were not engaging in the past with women, but the client spent 2 sessions, 2 whole hours, talking about a ruse, what really was a way to introduce something else. So I guess the client was testing the waters to see how shocked I would be at the various types of pornography that they claim to be addicted to. They didn't give up that label as porn addicted, but the real problem that they were experiencing was shame and embarrassment around their sexual proclivities. And so we have to normalize and reframe that and try to find out how we can assist with getting the desired outcome that they want. Desire discrepancy disorder, I just mentioned it. It's when 2 partners don't have the same libido, don't have the same taste in sex, don't want the same things in sex, and also don't see sex as meaning the same thing for them. One thinks it's love, the other one thinks it's excitement, one thinks it's adventure, the other one thinks it's holy, one thinks it's, swinging from the chandeliers, and the other one says, no, I want missionary. And you could want missionary 7 times a week, and the person wants to swing from the chandelier just once a month. That's a desire discrepancy disorder. In clinic at a hospital, many years ago, I had a group of psychiatrists, residents, we have mirror rooms, so they were behind the glass, observing a session at the clinic. And as I interviewed the client who had come in from being referred from actually child guidance, her daughter was in the child guidance clinic, and she said she wanted to speak to someone as well. They sent her to me. She started to speak to me about an experience she's been having pretty much all her life. And when people say that, you sort of imagine that they mean, as Jamaican people say, when I got to know myself. So she probably has been having this problem from adolescence. She was now close to 50. And what had happened was that she would become aroused unwittingly. She would experience all of the vascular congestion, etc., that's associated with sexual activity. And she would have an orgasm involuntarily whilst working. And this was causing her distress. As we were doing the interview, doing that intake interview with the 12 psychiatrists behind the glass, she actually began to be aroused. And I asked her, I said, are you having an orgasm? No. She said, yes, I think so. So I said, fine, I'll wait until you're done and we'll continue. We have to normalize the things that are happening to clients and patients, but they call them a client or a patient. This is her presentation. This is not something that she is able to, at that point, control, nor is she doing it to embarrass herself or to embarrass me. And without allowing that to happen and pass, there's no way we can get to how to control this. And there are exercises that we went through that assisted her in refocusing her mind, in being able to direct her energies elsewhere. And also sometimes, as you'll see, when I come to the persistent genital arousal, here we are, is that one of the ways that people deal with this is actually to either self-pleasure or to have intercourse. And whether it's partner assisted or self-assisted, sometimes that relieves the tension because the actual vascular congestion is real. The sensations that people feel are real. The orgasm is real, and it's possible without them touching themselves in any way. So one of the ways that they do relieve it is to actually bring themselves to orgasm, and they get some kind of peace of mind for a while. In many of the lay and internet descriptions of persistent genital arousal disorder, they try to find the most bizarre one, the one where someone is constantly all day long genitally aroused. That's not been my experience with the people who have come to me. And yes, I've had a variety of cases where the number of orgasms or arousals were vast, but there are also cases where it's not as persistent, right? So experiencing an orgasm, as I say, can give momentary relief of the symptoms for most people who are experiencing this condition, and it happens in men as well as women. So the man may walk around with a tumescent erection, he may have sex on the brain, if you like, far more often than the average man, but he is invariably somewhat ready for sexual activity various times in a day. And sometimes it really is just to relieve yourself. Way forward, how do we end this kind of cycle of people talking about sex addiction as if it were indeed an addiction? One of the things that we have to do is to use the proper labels for the things that are happening. We have to be accurate in our diagnosis and recognize that patients and clients tend to pre-diagnose before they come in. I often say that the condition is never the condition. When I ask a client, what brought you here today? They're telling me something that is quite different from what I hear symptomatically. And so it takes patience, it takes time to allow them to tell their stories, give you instances, etc. And often integrated practice where you're having more than one person in care of this patient or client is useful because often they're referred to by someone, whether it's a gynecologist, a urologist, a GP. If that's the case, then you can always refer back for medication and for giving this client 360 One of the things that's helpful is to reframe the presenting complaint to help them resolve multiple issues in a client-centered fashion. So by reframing it, you give them something manageable that they can work with. You give them something that helps them to break down the various things that they might be experiencing. And we had a great presentation on pharmacology. You ask about the medication that they may be taking. You ask about lifestyle. You ask about social activity, social responsibilities, etc. And help the client to arrive at a place where what they're experiencing is not only tolerable, but is also understood by them cognitively, using technique to reset the client. Of course, in all of these presentations, whatever we present is always just a drop in the bucket. So there's very much more, as Dr. Bailey says, we could do a week on sexuality, not just a day. And I thank you for your attention. And that's the presentation.
Thank you very much, Dr. Carpenter. I think most of us really found that very enlightening. Thank you very much also for your emphasis on, a non-judgmental, patient-centered approach, which is, I'm sure in your field, you have to take that approach because
Definitely.
of what you're dealing with, and these are real issues. So thank you so much. There are two questions. Well, one person is just a comment, sorry, that the presentation was wonderful, I agree. So the other question or comment/question is from Naranya Prasad. Dr. Carpenter, super insight. Would love your thoughts on contemporary sexual behaviors, allegedly excessive sexual behavior, such as polyamory and pansexuality.
Wow. Thank you for the question. First of all, these are not new issues. 25% of the world is westernized. which means 75% of the world is not westernized. And by the name, I'm assuming that you are between two types of cultures. Yes? Polyamory is not new. Polyamory is practiced in Islam. Polyamory is practiced in some Jewish sects. Polyamory is practiced by 75% of the world. These are not new. What we have is ways of explaining them in a Western context that gives them new labels. People are capable of loving more than one person. That has always been the case. And I think if you look at perhaps biblical texts, you will see that that is also in the Bible. Polyamory is very much in the Abrahamic story. I don't think he loved Sarah any less because he went into his concubine. So it's not new. Yeah.
Dr. Carpenter, for those of us who may be a little less
Oh,
educated.
what is polyamory?
Polyamory and pansexuality, thanks.
Okay, sorry. Poly, as it says, like multiple, and amory, loves, multiple loves, loving more than one person at the same time, simultaneously. And polyamory, used technically, has rules of engagement and is different from swinging, which is one of the types of open relationships, but it is a rule-bound open relationship. There are lots of different rules for safety and for protecting people's emotions, etc. And pansexuality has, again, always existed. If you look in the Bible, you will see that some of us are born eunuchs and others of us are made eunuchs, and still others choose to be eunuchs. And I'm quoting the Bible there. Yeah? And most religious texts have some reference to persons who express their sexuality in a non-heterosexual fashion. Pansexual means being sexually oriented or attracted to multiple sexual orientations and genders. That's pansexual. Yes?
Okay, final question. Do persistent genital arousal disorders require drug intervention, or is psychological counseling adequate? What do you think?
It depends on the degree and whether or not there's a comorbid condition. So again, the pharmacology presentation is very much appreciated because it speaks about, the kinds of drugs that are used in psychotic cases, in depression, in various other cases. So because it's the persistent genital disorder is not always paired with psychosis. However, the sex addiction story is often paired with some kind of pathology. So it might already be an indication for drug therapy along with talk therapy. And many psychiatrists work hand in hand with a psychologist. Many GPs, urologists, gynecologists work hand in hand with their sex therapists. So that is the kind of relationship we have in integrated care.
Thanks again, Dr. Carpenter. I think AGJP is going to have another one of these conferences with some more details, maybe some different aspects of this, because it's really enlightening. Okay,
Yeah.
I will go on to so thanks again. I'll go on to our final presentation, which is from Professor William AIKEN, who is well known to many of us. He's a professor of urology and head of the Department of Surgery, Radiology, Anesthesia, and Intensive Care at UWI Mona. He has many accolades. He's a fellow of the Royal College of Surgeons at Edinburgh, a fellow of the American College of Surgeons and the Caribbean College of Surgeons. He also has a master's in epidemiology, interestingly. Has been past president of the Jamaica Urological Society and Association of Surgeons in Jamaica. And he's done a lot of volunteer work with Jamaica Cancer Society's prostate screening clinic for many years. And is also an avid Rotarian and married with 7 children. I didn't know that. So I believe, though, that we have a pre-recorded presentation from Prof. AIKEN, right, Sam? So I think you can go ahead with that.
Good evening, ladies and gentlemen. I want to thank the Association of General Practitioners in Jamaica for inviting me to give this presentation this evening on genitourinary cancers, coping with the sexual sequelae. At the end of the presentation, participants should be able to state the prevalence of sexual dysfunction accompanying common genitourinary cancers, discuss the reasons for the associations of sexual sequelae with genitourinary cancers, discuss methods to screen and evaluate for sexual sequelae accompanying genitourinary cancers, and finally discuss treatment strategies to optimize sexual function after diagnosis and/or treatment of genitourinary cancer. I have no conflicts of interest to declare. So when we speak about genitourinary cancers, there are quite a number of cancers affecting both men and women. In terms of urinary cancers or cancers from the urinary system, we can look at the cancers of the kidney, collecting system, bladder, and urethral cancer, but that is quite rare. Bladder cancer is fairly common in both sexes, and so we're going to be looking at some data from that. In terms of genital cancers in the male, cancers of the prostate, penis, and testis would be the common ones, but we're going to be focusing on cancer of the prostate this evening. And in terms of gynecologic cancers, cancers of the ovary, uterus, cervix, and vulva are possible cancers, but cancers of the vulva are quite rare, and we won't be looking at that. When we look at the sexual response cycle, this was first put forward by Masters and Johnson in 1966. And based on their observation, they came up with a 4-phase model, including excitement, where there is increase in sexual tension, a plateau stage, followed by orgasm and resolution. This was modified in 1979 by Kaplan, who put forward a motivational dimension of sexual desire. And so in Kaplan's 3-phase model, you have desire, arousal, and orgasm. Of course, this is not to be construed as occurring in a linear fashion. When we look at male sexual health, there are 5 components that we generally look at. We look at desire, which involves sexual thoughts, fantasies, and initiating or being receptive to sexual stimuli. Arousal, which in a man, genital arousal is obvious with an erection. And then there is ejaculation and orgasm. And we look at the overall satisfaction, which involves components of all of these. Male sexual dysfunction mostly centers around erectile dysfunction and premature ejaculation, those being the 2 most common sexual dysfunctions. But men can have disorders of desire as well, and disorders of orgasm as well as sensation. Now, why are sexual sequelae associated with genitourinary cancers? Well, we know that with the exception of childhood cancers and testicular cancer, most cancers occur at an advanced age. We know that the incidence of sexual dysfunction is also age-related. And so age is a confounder, as well as the presence of comorbidities, which may both increase the risk of cancers as well as sexual dysfunction. We know that cancers themselves may directly affect sexual functioning. For example, locally advanced prostate cancer may directly affect the erectile nerves by local extension. And we know, for example, in advanced cervical cancer that women may have significant dyspareunia as well as postcoital bleeding. There's also the psychological response to a diagnosis of cancer. We know that the diagnosis of cancer is a life-altering event, and it's associated with significant anxiety, possible sadness, and depression. And patients are faced with possible imminent mortality. And so the brain being the most important sexual organ, if these negative thoughts are predominant, they will lead to an inhibitory effect on the sexual centers of the brain. We know as well, based on studies, that diagnostic procedures may contribute to erectile dysfunction, and we'll speak about that later on. And then there are many recommended treatments for cancer, including drugs, surgery, radiotherapy, and other therapies, chemotherapy, that may in one way or another cause sexual dysfunction. Now, we mentioned that sexual dysfunction is highly age-related. We know that from the Massachusetts male aging study, that 52% of men aged 40 to 70 years have some degree of erectile dysfunction. And from as early as 1995, Schiave published these normal age-associated changes in male sexual function, which are listed here, and I'll mention some of them. As men age, there's a gradual decrease in sexual desire, as well as a gradual decrease in penile sensitivity, a gradual decrease in the rigidity of erections, less erectile response to psychic stimuli, and associated with an increased need for direct stimulation of the penis, reduced duration and intensity of orgasm, reduced force of emission and ejaculation, decreased ejaculatory volume, there is a question of improved ejaculatory control. As men age, there is generally rapid detumescence post-ejaculation, and there is a prolongation of the refractory period. So these are normal age-associated changes in sexual function. And as we said, most cancers occur in older men. And so it's important to look at the baseline sexual function in these men. And as we'll see later, there is a high prevalence of sexual dysfunction in older persons, and this needs to be ascertained. So in terms of erectile dysfunction, in terms of an etiologic classification, we know that erectile dysfunction may be psychogenic in nature or organic, or in a lot of cases it may be mixed. Organic ED is mostly vasculogenic in nature, and occasionally there may be neurogenic causes, endocrine causes, end organ failure, and it may be due to drugs. Now, I mentioned earlier that there's a high baseline prevalence of sexual dysfunction. A number of studies, which I've included here, have shown that as high as 55.8% of men with newly diagnosed prostate cancer reported that they had erections strong enough for intercourse, which means approximately 45% of men didn't. In another study, population-based study looking at over 3,000 men, 45% of them with newly diagnosed prostate cancer had some degree of erectile dysfunction. And in these men, there were associated a high degree of anxiety and depression, and almost a quarter of the men reported to have a moderate to big problem with depression. So we see here that anxiety, depression, and erectile dysfunction are highly prevalent in men newly diagnosed with prostate cancer. Now, earlier we spoke about the influence of diagnostic procedures on sexual function. Here's a study that demonstrates that just a simple prostate biopsy may lead to a transient decrease in erectile function. At 1 month, there was a decrease in erectile function, but this still returned, recovered by 3 months. But in terms of orgasmic function, sexual desire, intercourse satisfaction, and overall satisfaction, these were significantly decreased both at 1 and 3 months in this group of 276 men. So we see that the diagnosis of cancer is associated with sexual dysfunction because it's highly prevalent in the age group of persons who are diagnosed with cancer, but also that these persons have a high prevalence of anxiety, sadness, and depression. They tend to focus on their mortality. There are concerns about body image and sexual functioning. And these negative thoughts and effects lead to inhibitory influences on the sex centers in the brain, resulting in a loss of interest and desire for sex, as well as affecting other stages in the sexual response cycle. Surgical treatment may result in sexual dysfunction. We know that castration for advanced prostate cancer removes the source of testosterone. 90% of testosterone is produced from your testes. And when men are either surgically or medically castrated, there is a loss of libido, and spontaneous early morning erections are lost, as well as they develop erectile dysfunction in the majority of cases. Also, surgical treatments may alter body image and lead to loss of confidence and avoidance of sexual activity. We know that the placement of a urostomy and ileal conduit may negatively impact body image, and persons with an ileal conduit may not want to engage in sexual activity. We know that removal of the penis, either partial or total removal for cancer of the penis, will significantly impact a man's sense of manhood and masculinity. A radical prostatectomy may result in penile atrophy, and of course, radical orchidectomy, where you completely remove the testes in testicular cancer, may result in body image changes that negatively impact sexual function. And then there are procedures that may directly affect the nerves supplying the penis, such as radical prostatectomy and radical cystectomy in men. So these two procedures are highly associated with erectile dysfunction. What about gynecologic cancers and sexual quality of life in young women? There was a qualitative study focusing on women 18 to 45 years, and a number of themes emerged from the study of these women. They had a high level of psychosexual distress. They had adjustment issues with adjusting to the diagnosis. They experience loss of confidence, fear, a sense of loss, some experience shame, and the altered sense of body image and sexual identity was significant, and along with the loss of confidence led to avoidance of sexual activity. These women, if they were single, when they were dating, they felt vulnerable in new relationships, and women who had partners experienced low sexual desire and experienced guilt about the sexual difficulties they had. Mitigating factors included open communication with their partners, emotional intimacy, and acceptance of the new normal. Aggravating factors included poor doctor-patient communication, which was perceived as absent, or doctors being blunt and uncaring. Sexual function after treatment of bladder cancer. So in this 10-year study, looking at both men and women, 3,279 persons were sent questionnaires, and there was a response rate of 55%. The median age of these persons was 75 years, and the vast majority of men. 31% of patients were sexually active after treatment for bladder cancer. So roughly a third of patients continued being sexually active. 66% of the women complained of vaginal dryness, and 80% of men had erectile dysfunction. 58% experienced ejaculatory dysfunction. And what was seen from this study was that those persons with bladder cancer who had radical treatment, meaning removal of the bladder, had higher rates of sexual dysfunction compared to those who only had endoscopic treatment. So we see that surgical treatment and the resulting sexual dysfunction in patients with bladder cancer, women with bladder cancer, may result in a shortened vagina. It may lead to loss of genital arousal, evidenced by lubrication, and it may also result in dyspareunia. And these are important to bear in mind when we operate on women for bladder cancer. So what are the predictors of patient and partner sexual satisfaction following radical prostatectomy for prostate cancer? Based on a review of the literature by these authors, I did a narrative review, and they found that the mental health of both the patient and the partner, as well as overall physical health, were important predictors of good sexual relations. They also found that the quality of the interpersonal communication between the couple was very important in being a positive predictor for sexual satisfaction. And most importantly, the perceived support from the partner was very important in overall sexual satisfaction. So these factors appear to be the most important predictors of sexual satisfaction for patients and partners in the post-prostatectomy period. However, there's a need for further research in this area because there are very few articles that actually focus on sexual satisfaction in the couple following procedures for genitourinary cancers. What about risk factors for erectile dysfunction after radical prostatectomy? Well, we know that the older the patient and the greater the baseline level of impaired sexual function, the higher the risk of postoperative erectile dysfunction. And of course, if the surgeon does not spare the nerves that supply the penis, then erectile dysfunction will occur. But even when these nerves are spared, in men who are older and in men who have a lower level of baseline sexual function, they will experience a higher prevalence of erectile dysfunction after surgery. There are many medical therapies that we give in genitourinary cancers which may result in sexual dysfunction. We mentioned surgical castration earlier, but we may do what is called medical castration, known as androgen deprivation therapy. And this reduces the testosterone in the blood to castrate levels. And as we saw earlier, this may result in a loss of libido, erectile dysfunction, and a loss of early morning erections in men. There are androgen biosynthesis inhibitors such as abiraterone and ketoconazole, and these may also adversely affect sexual function. And then there are anti-androgens and chemotherapy, which also may be associated with diminished sexual function. In terms of the hormonal agents, they work in a number of ways. You can give a drug that inhibits or impairs the secretion of luteinizing hormone by blocking the effect of gonadotropin releasing hormone on the anterior pituitary. And so that would be an antagonist, an LHRH antagonist, such as degarelix, or you may give an LHRH agonist, which initially stimulates the anterior pituitary and causes a LH and testosterone surge, but later on with downregulation of the receptors, you get castrate levels of LH and testosterone being produced. So both agonist and antagonist may result in castrate levels of testosterone. Estrogens used to be given in the older days, and this would cause feedback inhibition of the anterior pituitary as well as the hypothalamus. So these are some of the agents which we use. I've mentioned these already. So your LHRH agonists, such as glycerolin acetate or leuprolide acetate, and your LHRH antagonists, such as degarelix or pharmagon. These lead to castrate levels of testosterone. And of course, your estrogens, which are no longer favored because of the potent side effects. The non-steroidal antiandrogens actually block the androgen receptor, and there are first and second generation antiandrogens, which are mentioned here. And then you have your steroidal antiandrogens, which both block the androgen receptor, but also feedback inhibit the pituitary gland. This is an example of an LHRH analog or an agonist, Zoladex or glycerolin acetate. And this is your degarelix or pharmagon, which is used to bring about castrate levels of testosterone. Then we have the androgen biosynthesis pathway inhibitors in the form of ketoconazole or abiraterone, and these inhibit the production of testosterone, both from the adrenal gland, the testis, as well as the prostate cancer cells, leading to a further decline in circulating androgens. Now, recall that it is our responsibility to ask our patients about their sexual function. Patients may not volunteer this. And so in speaking to our patients, we need to properly evaluate their sexual dysfunction. And this includes taking a thorough history, which includes a sexual history, a medical history, a psychosocial history. And there are a number of validated instruments: the Sexual Health Inventory for Men, the International Index of Erectile Function, the Erection Hardness Score, which I'm going to show you later. These can all be used to objectively assess the degree of erectile dysfunction in men. And of course, having taken your history and used the validated instruments, a physical examination is important. We need to look for our secondary sexual characteristics. We need to properly assess the cardiovascular system, because recall that comorbidities that cause erectile dysfunction and other sexual dysfunctions primarily do so through a vasculopathy. We need to do a focused neurological exam, and of course, a genital exam is important. This is your erection hardness score. Grade 1, the penis is larger but not hard. Grade 2, it is hard but not hard enough for penetration. Grade 3, it's hard enough for penetration but not completely hard. And in grade 4, it's completely hard and fully rigid. So this is a very simple way of assessing the degree of erectile dysfunction. And then this is your Sexual Health Inventory for Men, or SHIM for short. And it asks a number of questions, 5 to be exact, and the score goes from 1 to 5. So 25 is the maximum, and 0 is the minimum. And it can be graded from 1 to 7, severe ED, 8 to 11 moderate erectile dysfunction, 12 to 16 mild to moderate, and 17 to 21 mild erectile dysfunction. So the higher the score, the better the erectile function. So in terms of the sexual history, you want to find out from the patient the precise problem that they have and how long they've had it for, whether the onset was sudden or gradual, whether it's progressive or it's remaining the same, if it occurs with only one partner, or if it occurs in with more than one partner, if the person happens to have more than one partner, or if it occurs with self-stimulation or partnered sexual activity, whether it's lifelong or acquired. Are there any early morning or nighttime erections if we're speaking to men? And how does the patient rate his or her sexual desire? Now, the key to the treatment, we're going to focus on erectile dysfunction because as a urologist, that's mostly what I would see. I don't treat female sexual dysfunction. But in terms of assessing and treating erectile dysfunction, you want to alter modifiable risk factors and causes. So if the patient smokes, you need to get them to stop smoking. If they have diabetes and it's not well controlled, you need to better control their diabetes. If their cholesterol is elevated, that needs to be corrected. If their patient isn't exercising, you need to get them to start exercising once they're able to tolerate it. So we always start out by looking for modifiable risk factors which are not well controlled and getting them better controlled. Then we'll go to our oral agents in addition to sexual education and counseling. If the oral agents such as your PDE5 inhibitors do not work, then local therapies such as your intracavernosal injections, intraurethral prostaglandin, or your vacuum erection device can be given. And then surgical treatments for those who have failed more conservative efforts. What is not on this slide is low-intensity shockwave therapy, which some studies suggest is proven efficacious in treating these men. Now, there's a concept of penile rehabilitation after radical prostatectomy. Typically, we will give a low-dose PDE5 inhibitor, such as Cialis, 5 milligrams daily. And the theory behind giving Cialis is that it facilitates improvement in blood flow to the penis, especially during nighttime, when patients typically would have nocturnal penile tumescence. Not that they have tumescence immediately after surgery, but generally that's when the blood flow to the penis will be facilitated by the Cialis. And the whole aim of this is to maintain the integrity of the penis by preventing atrophy, which tends to be a problem after radical prostatectomy. We can also give intraurethral prostaglandin pellets, but those are typically given more so in men who have some degree of erectile function after surgery and want to have sex. Intracavernosal injection with vasoactive agents is also sometimes used, particularly in those men who want to have erections so that they can engage in sexual activity. A vacuum erection device is also used along with your low-dose PDE5 inhibitors to pull venous blood into the penis to get it erect on a regular basis. And again, the whole idea is to maintain the integrity of the erectile tissues. The concept of if you don't use it, you lose it is very real where erectile tissue is concerned, because we know that it tends to atrophy with non-use. And then, as I mentioned earlier, low-intensity extracorporeal shockwave therapy has been found to be useful, but it's still considered, I would say, experimental, because some studies suggest it is efficacious, whereas others have not seen much in the way of efficacy. But patient selection is very important. The prevailing thinking is that low-intensity extracorporeal shockwave therapy probably won't work in severe cases of erectile dysfunction, but for mild to moderate cases, it has a place. So these are the things that we do to enable erections after radical prostatectomy. There's on-demand PDE5 inhibitors, but this will only work in persons who have some degree of erectile function and whose nerves have been spared. We mentioned intraurethral prostaglandin, which is not currently in our market anymore. We do have intracavernosal injection with vasoactive agents. We can either give prostaglandin E1, or we can give a bimix or a trimix. The trimix is locally available and is very effective in bringing about erections in men who are recovering from surgery. We mentioned the vacuum erection device earlier. A limitation with this, however, is that it can only be used for half an hour, and it produces a cold erection, and there tends to be wobbling at the base of the penis. We mentioned low-intensity shockwave therapy. And then if all of these fail, implantation of a penile prosthesis is possible. But it takes up to 2 years for men to recover erectile function after radical prostatectomy. So this would not be implanted until a man has been given an opportunity to recover his erectile function, unless we know for sure he won't. For example, in a man whose both nerves were sacrificed at surgery. deliberately because of the extent of the cancer. For those men who have hypogonadism, that is a low testosterone level, and they are symptomatic, and the symptoms usually include a loss of libido, loss of early morning erections, as well as erectile dysfunction. For these men, it is now thought to be safe to give testosterone replacement therapy. Once the testosterone level is documented to be low, the aim is to bring the testosterone levels to within the normal range and restore erectile function. And studies have demonstrated that these men are not at any risk of progressing, but they do need to be monitored carefully to ensure that their PSA remains low. So these are the various methods of penile rehabilitation following radical prostatectomy. As I mentioned earlier, male hypogonadism may accompany men who have had radical prostatectomy, and it is typically seen in those men who have symptoms of a low testosterone, so a low libido, absent early morning erections, erectile dysfunction, and a documented low serum testosterone done on at least 2 occasions, 3 weeks apart. These men, once there are no contraindications, such as a high PSA or active prostate cancer, these men may be suitable for testosterone replacement therapy. What about the treatment of sexual dysfunction in women? So I do not treat women, but a multidisciplinary approach is always favored, as it is in men. The involvement of the partner is crucial. We saw earlier where communication, good communication between the partners is important, and where involvement of the partner facilitates sexual satisfaction. Early referral for psychosexual intervention is important. For those women who have vaginal dryness, topical lubrication is recommended. And for those who have dyspareunia, they may benefit from trying different coital positions where the woman is more in control of the depth of penile penetration. The Plicit model is very useful in treating both men and women in terms of sexual dysfunction. So P stands for permission, LI stands for limited information, SS stands for specific suggestions, and IT stands for intensive therapy. So many times in patients who are suffering from sexual dysfunction, all they need is permission to go ahead and try something new. For example, in men, we commonly will remind them that sex is more than a penis and a vagina, and there's a whole repertoire of sexual activities that the man can explore. And just by mentioning this and giving them permission to do this, it may facilitate the couple engaging in renewed sexual activity. Limited in information, educating men and women about what is happening, the effects of the cancer or the surgery or the treatment on their sexual function, and an authoritative explanation may help them to understand better what is happening with them, and that may help. We saw earlier where poor communication between the doctor and the patient is one of those things which aggravates the problem. So information is very important. And then there are specific suggestions that we can make. For example, as we mentioned earlier, if a woman is having dyspareunia in certain coital positions, just simply suggesting a different position and encouraging her to be in control of the depth of penetration may be all that is necessary. Intensive therapy usually refers to psychosexual counseling and the various techniques that they would use in persons who have refractory sexual desire problems that are beyond the scope of treatment of a urologist or a gynecologist. So this is a Plicit model of therapy, which we've spoken about earlier. And this is what is used along with some of the techniques I mentioned earlier. We need to remember that the partner is very, very important in treating the patient with sexual problems after diagnosis of cancer. The involvement of the partner in their treatment and visiting the doctor with them, supporting them, giving them emotional support and empathic hearing, communication and engagement before, during, and after treatment, has been found to be extremely important in mitigating the effects of cancer on the patient's relationship and their overall level of sexual satisfaction. So I want to end here. I want to thank the Association of General Practitioners again for giving me this opportunity to give just a brief overview of some of the sexual sequelae we see after a diagnosis and/or treatment of genitourinary cancers, and a brief outline of how we may approach these. Thank you very much for your attention.
Thank you very much, Prof. Aiken. I'm not sure if he's online now. I see his name. Thank you very much for that informative presentation. There's one question. I think it was related to the slide that spoke about sexual dysfunction in females. And the question was, are these patients referred for pelvic floor physical therapy? And if not, I would assume such physiotherapy they're referring to can help. I don't know if Prof. Aiken is available to answer. Oh yes, seeing him now. Okay.
Yes. Good evening. Thank you for the question. Certainly, I mentioned that a multidisciplinary approach is important in treating sexual dysfunction in both men and women. And so if it is felt that pelvic floor physiotherapy will help, then certainly we would refer to a pelvic floor physiotherapist. And we do have a few of those in Jamaica who we collaborate with very closely to help to ameliorate symptoms that may occur after surgery, or indeed sometimes to ensure patients are in an optimal position before surgery. So yes, referral to a pelvic floor physiotherapist is something that we do in selected patients who we think would benefit from their intervention.
I had a question, Prof. Aiken, because you mentioned there's a lot of times, as you say, many patients who have had prostate surgery or prostate treatment for prostate cancer often end up with ED problems. It's not a general question, and I don't know if you can answer it specifically, but which treatment would you say is least likely to give issues with ED? Which treatment for prostate cancer? Or is that too broad a question?
No, it's not too broad a question at all. So, and I'm very happy you asked that question, because one of the reasons men may not screen for prostate cancer is a fear of the side effects, erectile dysfunction being chief among them. But what men don't realize is that the skill set has evolved, and the understanding of how surgery impacts erectile function has evolved to a point where we are able in appropriately selected patients to spare the nerves. So I would say that most men, once they do not have significant baseline erectile dysfunction, where the nerves are spared, most men will recover erectile function. However, if a man waits or does not come in for screening, and he waits until he has advanced or metastatic prostate cancer, invariably those treatments will cause erectile dysfunction. So the very thing that the man was trying to prevent by not coming in is more likely to happen the more advanced the stage of the cancer is. Because as I mentioned, bringing about castrate levels of testosterone is a cornerstone treatment of advanced or metastatic prostate cancer. And most men who have castrate levels of testosterone as a result of treatment will suffer from erectile dysfunction and low libido. Whereas if they had come in early to be screened and were found to have prostate cancer at an early stage, the likelihood of them maintaining erections after surgery at 24 months or regaining erections is very high. When you look at surgery compared to radiotherapy, initially right after surgery, most men will lose their erections, but over a period of 18 to 24 months will recover erections. Whereas with radiotherapy, 3 to 5 years out after radiotherapy, 50 to 60% of men will develop some degree of ED, erectile dysfunction, because one of the things that radiation causes is obliterative endarteritis. It causes the intima of the blood vessels to proliferate and the blood vessels narrow, and the tissues become relatively ischemic and undergo atrophy and fibrosis. So that's the difference between surgery and radiotherapy. With surgery, you lose your erections early, but they recover 18 months to 24 months out. With radiotherapy, you have a 50 to 60% chance 3 to 5 years out of developing erectile dysfunction.
Thank you for that very comprehensive answer. Thank you.
You're welcome.
Okay, Prof. Aiken, thank you again very much, and for taking the time, as I know you're quite busy right now. And I think, Sam, are we going to go to the answers to the pretest now?
Could I just say something? There were a couple of questions earlier. That there was a question about drugs that reduce ejaculatory volume. We certainly know that the alpha-1 adrenergic antagonists such as tamsulosin, terazosin, and others in that class definitely reduce ejaculatory volume, typically by causing retrograde ejaculation or decreased emission of semen. We also know that the 5-alpha reductase inhibitors reduce semen volume as well. And especially when men are on drugs like Deodart, which is a combination of the 5-alpha reductase inhibitors and tamsulosin, a lot of these men have anejaculation, meaning when they experience orgasm, there is actually no semen coming from the external meatus. So I just wanted to mention that because that question was asked earlier by someone.
Yes, thanks a lot for that. I won't ask another question. I was going to ask, and how do you deal with that problem? But then that may take too much time to answer that one. But thanks very much for explaining that. Okay, Sam, so are we ready for the post-test?
Yes, Doc, thank you so much. So yeah, we are. I'll have the post-test shared now in the chat, and you'll also get a copy of the post-test in your emails. So that's about it for the post-test. It's up and live, and persons can go ahead and do it now. So I think our next item after the post-test would be our vote of thanks.
So we're giving about 5 minutes for the post-test, or?
No, the post-test is live.
It's
Persons can go ahead and do it
okay, so
in
we're
their
not
leisurely time.
waiting. No problem.
Yeah.
So we'll go ahead and hand over to Dr. Bailey.
Yes.
Right, to do the vote of thanks. Thank you, Dr. Bailey.
Okay, thank you very much, colleagues. This has been really an intellectual feast. I know that the night is far spent, but you have stayed with us through almost 3 hours of really great academic stuff. I know you're now fully sated and academically equipped to go forth and manage sexual dysfunction in your patients. It was for me a special honor and privilege to be part of this team which conceived of this topic and to see it so elegantly and very comprehensively presented. We hope that in the very near future, we will revisit this topic in order to expand on some of the issues that were discussed. This particular seminar has been germinating for quite a while. It took us approximately 5 months, in fact, to really get everything together. And I must thank the AGPJ for joining with the MAJ Foundation in order to prepare this seminar. And special thanks must be given to Lynn and her team at the Secretariat for hard work over these many weeks. I'm very impressed with the quality of the IT. Sam and Oldgate Solution has again done us proud. Smooth, silky, very well oiled presentations. I'd like to thank Dr. Sophie AIKEN for guiding us through this interesting journey. You did well. My colleagues, Dr. Karen Carpenter, Dr. Jackie Campbell, and Prof. AIKEN, all made us very proud tonight with the high quality of their presentation, the skill with which they delivered, and the evidence that they brought to the table to convince us that the information they shared with us was evidence-based and worthwhile listening to. Thank you, colleagues, for a job well done. This particular function would not have been as successful as it has been without the help of our sponsors. We'd like to thank Madam Bex for coming forward and joining us in this venture. Finally, you, our colleagues, who basically dedicated 4 hours of your evening to share this special seminar with us. We thank you for dropping by and sharing with us. And we anticipate that you will all be getting your certificates shortly. So without further ado, let me again thank you all for coming and sharing this seminar with us. And we look forward to seeing you again very soon. Have yourself a good night, and for those who are traveling, a safe journey home. Bye for now. This is Dr. ALVERSTON Bailey signing off.
Good night, Doc.
Yeah, good night, Doc. Good night, everyone. Thank you so much. Have a wonderful evening, and we look to see you at our next event. Cheers.